Module 3, Increasing Cultural Competence to Reduce Mental Health Care Disparities, presented by Shirley Pandolfi, Cultural Competence and Education Manager of the Office of Diversity and Inclusion at the University of Mississippi Medical Center. Let's start by reviewing the objectives for this module. At the end of this presentation, learners will be able to recognize health challenges in a multi-ethnic world, recognize the importance of cultural competence in mental health, recognize the importance of the national class standards in health and healthcare, and identify tools and strategies to provide cultural competent care. Module outline. This presentation is divided in 4 parts. Part 1, background. Part 2, culture and cultural competence. Part 3, cultural competence, domains and standards. Part 4, tools and strategies to provide culturally competent care. Readiness assessment. As we continue with this presentation, please keep in mind the following questions. What is the role of culture in the delivery of mental health services? How the lack of culturally and linguistically appropriate services can impact mental health care? In recent decades, several key public healthcare reports and research studies on healthcare experiences, such as Confronting Racial and Ethnic Disparities in Healthcare and the National Healthcare Quality and Disparities Report, have indicated that particular cultural groups are more likely to be underserved, perceive negative treatment, and receive differential treatment outcomes. In response, healthcare systems in North America and other countries have endeavored to adapt their service delivery practices and policies to improve the quality and access of healthcare to culturally and linguistically diverse groups. Let's review the basic terminology for this module. Culture. Culture refers to integrated patterns of human behavior that include the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Competence. Competence implies having the capacity to function effectively as an individual and organization within the context of the cultural beliefs, behaviors, and needs presented by consumers and their communities. Cultural and linguistic competence are those set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals. Culture and mental health. Culture influences how individuals manifest symptoms, communicate them, cope with psychological challenges, and their willingness to seek treatment. Culture is central to the etiology of mental disorders as it provides standards for normality and abnormality. It determines the variations of normality in behaviors. While some cultures are tolerant of high levels of deviant behavior, other cultures insist on conformity. These differences can affect the rates of certain mental disorders. For example, attention deficit hyperactivity disorder diagnosis rates vary widely across countries, and these variations reflect the influence of cultures on the tolerability of certain behaviors in children and the perception and acceptance of the diagnosis. To provide cultural competent care, we need to be aware of stereotypes. A stereotype is a belief that associates a group of people with certain traits or characteristics. It's a prejudgment of a person based on a group the person might be associated with, tend to be fixed and oversimplified images or ideas. Culture is the method to understand a patient. When the social and cultural factors are neglected in the assessment of a patient, misdiagnosis and perpetuation of clinical stereotypes based on race, ethnicity, gender, among other factors occur, leading to disparities in mental health care. The importance of culture in mental health. Cultural differences are reported in the prevalence, clinical manifestations, diagnosis, treatment response, and outcomes for individuals with mental health problems. Globalization is making many countries culturally diverse, and this places an enormous responsibility on healthcare systems to ensure that practices are relevant to the variety of cultural backgrounds of the diverse populations, thereby reducing healthcare disparities through cultural responsiveness, appropriateness, and effectiveness of clinical services. Lack of cultural competence and cultural adaptations in systems of care is a leading cause of disparity in services for minority cultures, leading to poor uptake of available services, adverse outcomes, and increasing the cost to society. What is cultural competence? Betancourt, Green, and Carrillo define cultural competence as the ability of providers and organizations to effectively deliver healthcare services that meet the social, cultural, and linguistic needs of patients. Betancourt and Green also explain how the term cultural competence has evolved to reflect the development of skills that facilitate healthcare practitioners to embrace social cultural factors. For example, identifying and bringing communication styles to accommodate culturally diverse patients, and paying attention to their understanding of illness and treatment, which might include healing methods alongside Western medicine. Cultural competence definitions also include several attributes such as knowledge, skills, awareness, understanding, and sensitivity. The objectives of cultural competent care are to improve cross-cultural communication, enhance responsiveness to the healthcare needs of diverse patients, reduce healthcare provider discrimination, and reduce healthcare disparities. Cultural competency is a developmental process that requires lifelong learning. Let's review the three domains of multicultural competence presented by a number of authors in the field of multicultural counseling and psychotherapy. Awareness level. The first stage or domain is awareness, which is also called the beliefs and attitudes dimension. Here, students and trainees develop awareness of their own cultural heritage and values, as well as their negative emotional reactions, preconceived notions, biases, and stereotypes about other ethnic groups. They also learn to respect their patient beliefs, values, and cultural-based helping practices. Knowledge level. The second stage or dimension is knowledge. Here, students and trainees acquire specific knowledge of their own cultures, as well as the cultures and life experiences of their patients, including community issues concerning specific ethnic minority groups. They develop knowledge about cross-cultural communication, as well as cultural issues in assessment, clinical intervention, and the institutional barriers to mental health services. Skills level. The third stage or dimension is skills. Here, students and trainees develop specific clinical skills for assessment, counseling, and psychotherapy with clients from minority cultures. Students find appropriate resources for consultation and refer for their patients. They also learn to provide intervention at the institutional level. To be proficient at this level, students need to integrate information from multicultural courses with their own clinical courses, which ideally have also covered specific subject matters in a multicultural context. At this stage, the students are ready for hands-on experience. Having in consideration the diversity of the population in the United States and the importance of mental health and health services, the Office of Minority Health developed the National Cultural and Linguistically Appropriate Services Standards. These are guidelines that inform, guide, and facilitate practices related to culturally and linguistically appropriate services. The intent is to advance health equity, improve quality of care, and eliminate healthcare disparities. Let's take a look to the national class standards in health and healthcare. The standards are 15 and are divided in 4 sections. The principal standard is designed to frame the essential goals of all standards. We cannot provide cultural and linguistic appropriate services if we don't follow the standards from 2 to 15. The second section of the standards talk about governance, leadership, and workforce. It's so important to advance culturally competent care in the organizations to have the support of our leadership and governance, have policies, practices, and allocate resources to provide cultural competent care. It's important to have our workforce trained and educate leadership, governance, and workforce regarding linguistic appropriate services. Communication and language assistance. This is the third section of the standards. Highlight our work with patients with limited English proficiency. We are required to provide interpreters at no cost for the patients, as well as translated materials for the patients. Also, these standards mention never use minors as interpreters and to have signage in the language commonly used in the population that we serve. The last section of the standards talk about engagement with the communities we serve. Be able to partner with our communities and be able to collect data regarding those communities that are seeking services in our organizations. In this case, we will be able to plan, have goals, and provide services by identifying what are those communities that we are serving. The American Psychiatric Association, APA, and the DSM-5 Cross-Cultural Issues Subgroup came together to produce and disseminate a tool at the vanguard of cultural psychiatric practice, the Cultural Formulation Interview, CFI. This evidence-based tool is composed of a series of questionnaires that assist clinicians in making person-centered cultural assessments to inform diagnosis and treatment planning. The CFI has 3 components. The first component is a core interview of 16 open-ended questions with prompts for clinicians to understand the cultural context behind each question. It is divided into 4 domains. Domain 1, cultural definition of the problem. This domain seeks to incorporate the patient's own view and language of his illness experience. The questions in this domain first inquire about the reasons for the visit, noting that the person's understanding might be different from that of the provider. The CFI also asks about how these circumstances are described to people closest to the patient, noting that those explanations might differ from how the problem is described to the clinician. The rationale for the first two questions is that the way a problem is understood, whether it is defined as an illness, might take on many forms, and a person's description of the situation might depend on the relationship with the interlocutor. Domain 2. Cultural perceptions of cause, context, and support. The first set of questions in this domain aims to clarify what a person and his social network consider to be the origin of the problem. Domain 3. Cultural facts that affect self-copying and past help seeking. This domain builds on domain 2 to explore what the person has done in the past to cope by himself with the situation and to seek treatment or other forms of help. In light of the answers provided about stressors, support, and cultural identity. Domain 4. Cultural factors that affect current help seeking. This domain explores the person's preferences for future care as well as those in the social network. It also addresses any concerns about the clinician-patient relationship. This slide summarizes how cultural competence works, and the big key is asking the right questions. For example, what do you call your problem? What do you think caused it? Why has it happened to you? Why now? Here are some strategies that you can use to be able to connect across cultures. Develop and maintain understanding of the history, tradition, values, family systems, and communication patterns of the major patient groups you serve. Develop and maintain knowledge regarding the influence of culture on health-seeking behaviors and perceptions of health, illness, healthcare treatments, disability, caregiving roles, and death and dying among the patients groups served. Demonstrate genuineness, empathy, warmth, openness, and flexibility to facilitate patient engagement throughout service delivery. Use cultural mediators, such as bilingual staff if they are trained in interpreting and cultural mediation, outreach specialists like health promoters, intercultural mediators, patient guides, and the new generation of patient navigators. Also, train professional interpreters. And don't forget to partner with communities. Let's review this case study based in a real story, the experience of Dr. Balcozar, a clinical professor of psychiatry at the University of Missouri, Columbia, and published in Psychiatric Times. A 10-year-old girl arrived to the psychiatric department for depression. She had been diagnosed with cancer, and the oncologist recognized the need for a psychiatrist. The Gear family had recently migrated from the Middle East. They view cancer as a death sentence. They believed God would heal her, so they resisted their oncologist treatment plan. They didn't even want the Gear doctors to use the word cancer when he talked to their daughter. When the Gear said God hated her for making her sick, her mother told her to repent. The last thing they wanted was a psychiatrist to get involved. The girl threatened to jump from the hospital window because she worried the medication would poison her. She was irritable, angry, and unable to concentrate. She had nightmares and did not want to play video games or see her friends. Her parents kept her home from school for a month because she was sick. Formative assessment. What tools can you use to conduct a cultural assessment in this case study? What are the shared values influencing mental health seeking behaviors in this case study? As the psychiatrist in this case, what would you do to provide culturally competent care to the patient? So, what to do about culture? As a healthcare provider, you can do three big things. Remember that each client or patient is culturally unique. Spend time listening to your patient before developing a treatment plan. Consult interpreters and or family members as needed. And remember, your best source of relevant information about culture is your patient. Here is a list of the references used to develop this presentation.